Welcome to the Rural American Surgeon. I'm your host, Dr. Randy Lehman, a general surgeon from Indiana. This show is tailored around the nuts and bolts of rural general surgery practice. You will find topics such as practical surgical tips, rural lifestyle, finance, training, practice models, and more. We have a segment called Classic Rural Surgery Stories, where you'll get a feel for how practice in the country differs from the city. If rural surgery is your passion, this show is for you. So, now that the ChloraPrep has dried, let's make our incision. Welcome back, listener, to the Rural American Surgeon Podcast. I have a very special episode for you guys today, something that I thought was a very interesting and compelling story. It has very much to do with rural medicine. And I welcome my friend and not relative, Dan Leman, spelled differently, to the show. Dan is a PA, and he was involved with an interesting tech startup that had implications for treating people that are underserved in rural Colorado and other places. And so, Dan, thank you very much for agreeing to come on the show. I really appreciate it.
Good to be here. Thanks for the show.
Thank you. So tell me a little bit more about yourself, your PA training, what you've done throughout your life, and what you're doing for a career now.
Yeah. No, thanks. So I started in medicine as an EMT on an ambulance here in Colorado and worked in the ER for a while and decided that I didn't want to be a doctor because who would want to spend that much time in school? And I was also married and had children at that point in time too. And so with that, I went to PA school and did that when I was 25 and came out working in urgent care and got bored. And so pretty quickly in, maybe 2 years into being a PA in an urgent care, a friend of mine said, "Hey, you remember that old ER doc that you used to work for? He started a telehealth business and he's looking for a PA. Why don't you check it out?" And so I called him up and said, "Hey, I hear you're looking for a PA to do telehealth. I don't really know what it's about. You know, this is 2018, so pre-COVID." Mm-hmm. And so we met in a coffee shop and it was just him starting a telehealth business. And really his vision at the time was Colorado, and specifically Colorado Medicaid, will reimburse for telehealth. And there's a real need in rural Colorado for that modality to actually bring care to patients. And so early on, he said, that's what I want to do. I want to be able to bring care to where it's not through technology. Then became my partner. He had developed his own software. He was an ER doc by training and had done that for 20 years, but decided that was where he wanted to go. And so I worked for him for a while doing telehealth, and we can get more into that over time. But we developed not just the telehealth platform, but through COVID did some special projects, ended up developing some of our own hardware and getting to a spot where we were working both in Colorado and even in other spots around the world with our hardware. And it was going okay. And there was a lot of potential there, but for a variety of reasons, I transitioned out of that business and moved into a kind of a career pivot to work mm-hmm. for a nonprofit organization with a mission focused and specifically involving Haiti. And so you've been involved in Haiti as well, and you've worked at the same hospital. Actually, part of it was I had done some training at Bonefin Hospital when in PA school, and some ties down there with my wife's family. And so I ended up working for the last almost 3 years for this nonprofit out of medicine almost entirely, but there is a hospital that is underneath that management now and several other different ministries that we operate in the country of Haiti.
Yeah. So to be specific, our church is involved in international missions in multiple ways. We've been in Haiti since the 70s. And we have several different things: child sponsorship, some construction things, some orphanage interests, and a hospital interest, not maybe all under the same umbrella. Very good. And that is, there's rural surgery in America, which is really what this podcast is about. But I also do some international missions myself. And I think that there's an extension. I know there are a lot of people that are developing rural surgery tracks in the United States. And some of the people that are interested in developing those tracks to better serve the needs of rural America are also interested in international missions. And certainly if you're going to be a surgeon and you're going to go to Africa or you're going to go to any other developing country and volunteer, if you go and have the ability to do a C-section, you might save a life, or some of these other subspecialty things that are outside of maybe traditional general surgery. And then also just being able to be flexible.
that's the first I'd heard of rebar for X-Fix, but I do know that they've used mosquito netting for hernia repair in Africa.
Yeah.
Certain things, you're not going to have the full tray of things that you normally have at your hospital back in the United States. So for the How I Do It section of this podcast, I want to talk about what exactly you guys did with this telehealth. What was the software? What was the hardware? How did it go, both in the U.S. and abroad, and then where is it now and everything? So, and why? So let's start with, first off, what was it?
Yeah, so it started with just software, and the development there was kind of the early stages of a waiting room software where people could come in electronically, be in a waiting room, and get pulled out for different to different docs, and so it had the capacity to be able to connect different patients to different specialties, and there was a lot of pieces there. And so that part was developed before I came on board, and I think maybe one of the lessons from that is, one, software development is super expensive, especially then. Maybe AI is changing that, and the use cases are ever changing, and so to jump into the software game takes a lot of capital, but it was worth it at the time. And so we used that for a while. And then through COVID, the state was asking for some help with their jails to be able to do telehealth in the jails and connect better their patients, both for behavioral health and for medicine. And so we got into starting to provide some products. And with that, there was our desire, as we provided urgent care around the state, was how do we get the data that we need so that we're not just making educated guesses, but we don't really need to be there for a lot of these things. How can we connect in patients? And so we started bringing together technologies and ended up developing what ended up being essentially a briefcase that, with a trained person, had heart and lung sounds via stethoscope, an EKG, ear, nose, and throat skin camera, all with a battery pack contained, and then cameras and screens that the operator, the doctor, could operate from afar so they could move things around. Mm-hmm. All of that was in one briefcase. And then with that, we would train individuals to be able to carry that and be the hands basically of the doc to be able to get a good exam. Mm-hmm. So that developed also with another partnership with the Colorado Coalition for the Homeless, where we did a street outreach program with them, where we actually developed backpacks so we could take those briefcases on somebody's back. We'd have legs pop out of the backpack, and they could just set up shop right on the street. We would see patients right like that with a nurse who would go out with that and then connect. And in that case, and in rural Colorado, we would see patients often who would say, I would not have come in to get seen if this technology didn't exist, because I can't drive an hour and a half to go see somebody. And that's how far it would be. But I have an EMT in my own hometown who can connect me in to be able to do this.
Were you in any other states?
We did not. We just operated it because we were probably one of the only telehealth programs to use PAs. And so we elected to keep our licensure just within Colorado. Mm-hmm. And so we did see all corners of the state, but we just stayed in Colorado.
Okay. And then in Bolivia, you said, right? What did it actually get used? Patients actually got seen there?
Yeah. So there's the two sides. We had the healthcare provision side that we saw patients. That was just in Colorado. And then our hardware and the briefcase and all of that, we worked with a lot of different programs. So we worked with a program out of Miami that was working for homeless. We worked with a program in Bolivia where this was a cardiology specific program with Chagas disease. We partnered with a local public health organization, and they had patients 6-8 hours away from any cardiologist. And so we went and trained a local health professional. So I went down there and trained them and had cases there, and they're still using them, is my understanding, connecting those patients back to cardiologists to treat their Chagas disease so that they don't have to commute that 8 hours.
And they can do a tele-EKG. And
tele-EKG is live, and then the stethoscope is better than you would have around. Like you can use the stethoscope as a regular stethoscope, but then that transmits through to several cameras so that you can get a full exam on the patient. And so you can't do procedures necessarily that way, but for somebody who's getting just medication treatment, it was excellent. And we could do it in their house. So we also set up with satellite and phone. And
so last question on that. Are they still doing it in Colorado?
So the company is still seeing patients in Colorado. We closed down the hardware side of it.
Why?
A few pieces. So we really wanted to leverage the hardware with trained in Colorado, especially in EMT. We actually did a grant program where we developed a camper van with similar equipment, and that was going to go out. But the reimbursement model for it just wasn't there. There was I don't know if you're familiar with the ET3 program that was out for a little while that Medicare put out, where they would reimburse for emergency calls to go to non-emergency room locations. And so instead of forcing every ambulance to take a patient to get paid to an ER, they could use telehealth as an example. It never went through. Most insurances didn't really want to comp the same amount for a telehealth visit. And so you're trying to pay for your doc, you're trying to pay for your EMT and your equipment, all of it. And the reimbursement model wasn't there at that point in time. And especially with the state, our big push there was with the state Medicaid population, and the state really wasn't interested in enabling it to really do well. And so at that point in time, my partner's interest, the one who started it, was much more interested in the software and the telehealth side without the hardware. That was his skill set. My skill set moved more into the hardware side. And so when I moved on, it was better to shut down hardware. The other piece there, sorry, I'm getting long-winded.
Okay, we'll just cut it off.
Yeah, there you go. 2 second sound bites. That's all you need. Iteration is hard. I mean, I think that's the other piece of it. It takes a lot of money to continue to build software and hardware. And from a small business standpoint, to get the capital and all of the different pieces in, we were talking about building, batteries and bringing in components from China, and, you're laser cutting some different things and assembling. And I was building these things in my garage for a while. And that sounds cool if you're Bill Gates and you've made billions, but when you're not Bill Gates and you haven't made billions yet, it takes a lot, and it just wasn't worth the resources.
Love it. So that brings us to the next segment of our show, which is a financial corner. And I had a thought about this. So I remember hearing about or reading, I can't remember, a New York Times article where they went around and interviewed people on the street. What is the most likely way that you're going to get rich? And when I heard the results, number one was inherit it. Number two was win the lottery. And number three was sue somebody.
Interesting.
I was very disappointed when I heard the results.
You haven't tried any of those, have you yet?
None. Yes, exactly. Not counting on them. My three, at the time I thought about it, I think I heard about this maybe 5 years ago or so, was, step one, hard work. It would be the most likely, most reliable. Step two, investing. Step three was maybe invent something. And so that's where it ties into what you're talking about, because if you can change just how something is fundamentally done, you can and should be compensated well for that, in my opinion. And if people put more creative energy into maybe that, I mean, I think there's a lot of creative energy that is being put into that. And I think that America has just been a breeding ground for all of this amazing technology and advancements, just overall, the light bulb, the fact that we're recording this at night on, Riverside, and it's going to be podcast everywhere. And it's ho hum at this point. It's just unreal, airplanes, combustion engine, jet engine. It's just amazing. And not, that doesn't even mention all of medicine, most of which the biggest breakthroughs were by accident, but that's all right. Still, there's enough energy being put in that. But if people would put that much energy as they would trying to sue somebody for some money, maybe just into some of those other things, definitely the world would be a better place. I don't know where we would be exactly at. But I want to ask, from a financial corner perspective for you, to share some of the, as much as you can or know or feel comfortable, the financial aspect of inventing this software, and would you tell somebody else to try and do something like that? And what lessons did you learn along the way?
Can I speak on the hardware side instead of the software? Because that was more my skill set. The hardware side, so we went all the way to, with that backpack and the legs and all that, I wrote 2 or 3 provisional patents. Mm-hmm. And so we went down that road of like thinking, we can be that Shark Tank inventor who's just going to get millions, And we were in that world to some degree as well, just floating around with other companies, talking to some VCs and deciding whether to go there or not. I think there's a few things that I learned from it. And one is anybody who's involved with venture capital, but that it's not a great environment. And for both my partner and I, the hype and the sleaze were not worth it. And so we made a conscious decision to not go that route, to not seek money because we didn't want to try and oversell something. I think the second piece was, when's the last time you've heard of an invention in the last 20 years that was just a single person who didn't just build it up? Everything with technology the way it is today takes a ton of capital and other pieces that come together to be able to invent that. So I don't mean to be a Debbie Downer. Like I think there's a lot of potential there, but the percentage likelihood is low. Even some of the cool things like that we were seeing with some of our others that we worked with in different startups, the ability for them to take the biggest step forward was less on the technology specific side and more on a business model side that was innovative. And so I think that's like the Uber who took taxis and said, all right, how can we use technology to disrupt this? That to me is sort of the 20th, the current century invention is the disruption of the old into something new.
Yeah. Through software, which was not the hardware piece kind of like came in.
Right.
So that's great insight. And it's kind of what I expected you to say actually, but all right, great. Let's move on to the next segment of the show that's called the classic rural surgery stories. These are the stories that your counterparts in the urban environment would never believe. And I actually had a story for this since
I'm not a surgeon.
You're not a surgeon and I happen to be. And we have this connection with the hospital in Haiti.
Yeah.
I had a story from there. So it doesn't get much more rural than Bonefin, Haiti.
Literally, can I describe it?
Yes, please.
So I think it's worth noting that the hospital there is, the town itself is 400 people, if you can call it a town. It's a 120 bed hospital, 4 ORs. So the hospital compared to town size is just ridiculous. The road to get there from the main highway, which is paved, is, I heard this week, 9.7 miles. It's unpaved and it takes probably an hour.
Yeah.
And in the last 3 years, the rains have made it a lot worse. So the degree a 4-wheel drive vehicle will make it and a motorcycle will make it. That's about it. Your Honda Accord's not going to make it up there right
You
now.
need a mule.
You need a mule. And
The
so
9.7 miles an hour is if I'm doing the math correctly.
You're doing the math correctly. Yeah.
What's the elevation?
It's like 2,000-3,000 feet.
Best part about Bonefin is not so many bugs.
And it's cooler.
And the heat isn't so bad.
Yeah. On a motorcycle, I made it in like 23 minutes.
Yeah, that's not too bad. 23 miles an hour average.
I'm sorry. No, that was from the main town.
Backwards. I got to do my math.
That was, so just the dirt section, it was probably only like 12.
Oh, okay.
That was a long time ago. Anyways, that's the setting for the hospital.
Yeah. And you're an aggressive motorcycle driver. So
you've never ridden with me.
Yeah. So my story in Bonefin happened when I was a 4th-year medical student, and I went to Bonefin.
When was that?
It was in 2015.
Oh, I was there just before you. I did my 2 months. I finished December of 2014.
Yes. So I came literally the next month, and I was there for a month. And because you were baking cookies for all the staff, that's why they didn't like me as much.
Yeah,
so this happens to me everywhere I go. Mm-hmm. So basically, the team had an orthopedic surgery team coming for 1 week. I was there as a 1 month med student elective rotation, basically in global health. And I spent time in the ER, but obviously spent as much time as I could in the operating room. Operated with some of the Haitian doctors, the Haitian OBGYN in particular. That first week was by far the most impactful, but in a negative way. And what it gave me is, we learn from our mistakes and mistakes of others. And that's one of the things that I hope to do with this podcast is share, as much as is appropriate, lessons learned. And one lesson that I learned from this particular experience was that we had a patient that was a young man, a healthy father of 5, and he had a motorcycle accident, and he's laid up in traction for a couple months waiting for an orthopedic team to arrive at this hospital. Motorcycle accident is pretty common down there. He is alive, right? But he ended up having a hip fracture, a femur fracture, and a tib-fib fracture. And here we are, an orthopedic team. So the patient was listed for surgery, went for a repair of all of his fractures in one big whack. Well, monitoring, intraoperative labs, things like this, it's not the same in that environment. And the patient really was actually fairly stable through the operation, but the operation took a long time. And not necessarily longer than normal. It's just that there were 3 separate pieces to the operation. And after the surgery, we took the patient to the hallway, and then he coded and just went unresponsive, and no pulse. Brought him back in. We resuscitated him and got labs and things. And it turns out, what we didn't really notice in the United States, maybe, we would have more of a robust monitoring system intraoperatively. And there would be also all sorts of resources available to us, such as transfusion. But there was a lot of blood in the sponges and 2 full suction canisters, essentially, of blood just from sucking throughout the case while, the operating surgeon's so focused on the task at hand. The patient's hemoglobin ended up being 3. When we withdrew it while we were doing the resuscitation. So after we found the patient's hemoglobin was 3, we had to weigh our options, and we had no blood available. Now because of this experience, they've actually created more of a walking blood bank, from my understanding, at BoneFin. You aware of this?
Huh.
I think there is, or there was at least talk of development.
They're connected with the blood bank down in Lakai. In town, and so there's some of that, but I don't know if they carry, I should know that, but I don't know if they carry like O blood there or anything.
Like just having a listed group of people that they know what their blood types are, that they could call them. That's what I mean by walking blood bank, and come in and donate now.
Yeah, maybe they do.
I think that they do.
Out. Yeah.
Well, long story short, we didn't have any of that set up at that time. And we didn't have an ICU. We just had a hospital floor. We had the operating room, the team was, a very limited team of people. And if I had to, if it was a year or 2 later and I'd done my ICU rotation, I was at that time not really much of a meaningful contributor as a 4th-year medical student. But basically, our only option was we transfer the patient back to the floor and give him fluids, because he was no longer bleeding. It's just, sustaining that. So we did resuscitate him, but we had to send him back to the floor, and then he ended up dying that night. And effectively, any good that we did from that whole trip in terms of a utilitarian aspect is totally undone by the, 5 orphan children that are, orphan, but, they're left with a single parent, and just makes you feel terrible. And there has to be a lesson that has to be learned. And I think that people need to hear this, especially if you're considering international missions. You have to be first, do no harm. And it's not that we're trying, obviously we're trying to do our best, but then the outcome is just so miserable. So that's the rural surgery story. That it's really an international surgery story. It's still relevant, I think, to rural America, because, when you're in a hospital that has no ICU, doesn't have cardiology, doesn't have dialysis, that we're all practicing in these critical access environments, then you have to consider, should I take this patient? And then there's elective versus emergent patients that present to you. And I'm living the same conundrum that you all are on each individual, given patient. And it also depends whether you're in rural America in a place where you're 6 hours by fixed wing aircraft to a referral center, or if you're like where I am in Indiana and you've got ICU capabilities 45 minutes away by ambulance, or 2 hours to Indy or Chicago. So
can I poke you on that story just a little bit?
Sure.
So two things that I think about. One is not related to missions in general. How does you operating in different settings, because you operate in 3 different hospitals, right?
4, yeah.
4. And so I think about like this team coming in, and I've been on a bunch of different medical teams in different places around the world. I shouldn't say around the world, Mexico, Haiti. And the mindset, it's when you're outside of your normal routine, it's easy to compromise something that you forgot that you took for granted. And so would that kind of a surgery have, even if they had elected to do all 3 repairs or whatever they did, what would have been different in the US when you think about just some of the different pieces that are there that even the surgeon coming into a new setting just took for granted and didn't think about? And what's the lesson, like, as you see yourself in different settings, how do you apply that today to make sure you're not, when something outside of the norm comes, what do you do differently when you have, like, I think we talked earlier, like a family member coming in, you don't have to share that story, but just that was outside of the norm. And all of a sudden normal things that you have in place are took for granted. How do you reconcile that, or what lessons have you learned from that? How do you make sure that you don't miss something?
Well, if you're a surgeon that is thinking about doing international missions, on the first time that I would go on an international mission, I would make your sphere of what you do tighter and make it more towards the middle, if possible.
Have more precaution than you would at home.
Because there's these unforeseen things that could come up and make things harder. At the time, again, I was a med student, so I don't think, and I'm not an orthopedic surgeon, so the nuance of the repair and the choice of incisions and all this, I really don't know, but I assume the patient could have just stayed in traction. We fixed one fracture, go back to the operating another day after he's stabilized. And in retrospect, that would be the thing to do, the obvious thing to do.
But they were only there. I'm sure there's some thinking, which I've seen a lot of, like, we're only here for a week. Like, if we don't do it now, this guy's going to be in traction for 3 more months on this other whatever. And like, well, let's just compromise and get it done.
Yeah. And so that's the question. And probably the surgeon, now being a surgeon, I can just imagine, and doing international missions, the focus on doing the operation well and the missing of the big picture was probably one of the big downfalls there. So that's the other thing you want to do is, what's the perception of the community or the family on this scenario? If he walks with a limp, okay, not as big of a deal as the worst possible outcome. So you have to really protect your downside risk for those worst possible outcomes and really be aware of it. Now, there's things that can happen, and I always say, like, this, the patient takes the risk, not the surgeon. And you have to focus on that informed
especially
consent.
In those settings. There's no liability in a sense for those physicians. I think that is something to keep in mind too, of just, and you probably see it in the US as well, in some of the more health illiterate population, where it's so easy to come in and just be like, this is what we're going to do. This is what's best. And, to a Haitian, you're just like, wow, like, an American surgeon is going to work on me. Like, it'll be perfect. Yeah. That's just the mindset that's there. And I think we can take for granted that doctor-patient relationship gets diminished in those settings. People are excited, like, oh, for Jesus, we're going to come and do these things. It's like, well, but did you value that person enough like you would value your wealthy patient back home? Or not to use wealth as a
there's
indicator,
so many lessons that the surgeon learns from the international missions. I would strongly encourage someone. I don't want to scare anyone away from doing international missions. There's so much. It's so refreshing. It can combat burnout. You don't have to wrestle with the computer. Your patients generally are much more grateful. You're performing a surgery that, truly in the United States, if I didn't exist, like, most of the same operations are still going to happen. I'm providing certain things. I'm enhancing the quality of life in my county. There's things I'm definitely doing that if I didn't, nobody else would, but not so much the actual surgery that you see when you go internationally. So please go, but you need to just go with an open mind, be thoughtful, and then allow that experience to impact you just as much as you're impacting the people there.
Yeah, no, I agree. And I do think there's one other piece to that, which is going with or to a place that you fit into a system, whether it's because of follow-up care or whether it's because, if there is a local surgeon and then you show up, well, of course, everybody's going to want to go to you. Like you're Randy Leman.
You don't want to hurt the
right. You don't want to hurt that, but then also you do have things that you can leverage for that local surgeon. And so I think doing it within that environment that's going to be best, as you already said, short term and long term.
Yeah,
for the community that's there.
I've never been with PAACS, but I know several surgeons that have been with PAACS. PAACS is focused on training surgeons in Africa. Maybe we can throw a link to the show notes and in for that. We can also potentially link our organization as well. Yeah.
We're not sending medical teams right now. Haiti's in not a great spot. So we can't really travel there. Although most of what we have been doing is teaching teams at this point.
So you'd like to do that. The book, like Where Helping Hurts, these are all things that you need to think about. But for an individual that has no experience, I think going and doing and seeing is a good start. And then some people are going to really be, called to that line of work and go on and do the things that really need to be done. And people that are moving, I have a good friend that's moving down to Honduras semi-permanently, basically, and in some ways probably giving up a practice in the United States permanently because it might be hard with that gap to come back. Many practices won't hire you back, and there's lots of things. So, for me now, I have a trip that I go with BMDMI to Honduras. Now, basically annually, I usually bring several people of my own team with. They have it all set up. They have pre-selected. It's run by a pharmacist and her husband, and she has a really good understanding of those types of risks. So the patients show up on the clinic day at the beginning with their EKG, their chest x-ray, their labs, all their imaging, their gallbladder ultrasound printout. They show me it's just, cholelithiasis, and they've been pre-selected for comorbidities. So most of the people that show up and they get surgery, but they see me and then they go see anesthesia afterwards, and everybody has to agree. And it's based on their experience that they've been able to kind of build this. So then we have much less in terms of follow-up mess that we leave, behind. But that's, one big issue is who's taking care of the patient after you leave. That's always a question. So you just have to talk to the organization that you end up, thinking about going with, and trying to make sure that you leave things better than you found it, just like, we do with everything in life. So.